multi-system autoimmune inflammatory CTDs. And one among that, I'm not really sure we call it as a CTD, but for the time being, we're calling it as a CTD. It's better to call it just a multi-system autoimmune disease. And those three very, very important multi-system autoimmune inflammatory CTDs that we're going to discuss are IgG4, sarcoidosis, and Sjogren's syndrome. So to study this in detail is absolutely not required now. What we are trying to do is to compare and contrast between the three diseases to get a wholesome understanding, and that's going to be the whole purpose. And very important, every time you have a question on sarcoid, options will be IgG4 and Sjogren, and vice versa also. So very important discussion. Let us start off with IgG4 related disease and just try to draw comparisons at each point. So IgG4 related disease is a very, very new kid on the block, right? So the issue is that we have been previously having so many conditions, now which we have reclassified as IgG4 related disease. So the basic understanding came from many conditions, which is classical example that's been described as a type 1 autoimmune pancreatitis, because type 1 autoimmune pancreatitis was an entity, a name which was actually in use for a long time. And in this type 1 autoimmune pancreatitis, we had young people presenting with recurrent episodes of pancreatitis and nobody had any idea as to what it was. Later on, they found out that the biopsy specimen had a lot of IgG4 containing lymphoplasmacytic cells. So like that, we found out so many diseases where there has been excess of IgG4. So let us try to answer the two most important entrance questions. Why IgG4? So this is again not a very clear question. I mean, we don't have a clear answer for that. We're having so much of a chronic antigenic stimulation. Yes, this chronic antigenic stimulation, we don't know the antigens. Only one antigen has been identified. That is the first MCQ question, galectin-3. So many antigens are there. We don't know exactly what it is. Only thing we know is galectin-3. And this, of course, is because of this chronic antigenic stimulation. A lot of antibodies are being produced. Inside this, IgG4 is also being produced. Okay, inside this, IgG4 is also being produced. Due to some nitty-gritty, some reason, this IgG4 is actually being produced a little more. Okay, IgG4 is being produced a little more. But IgG4 is different from IgG1, G2, G3, as you would have studied in immunology, because IgG4 doesn't bind the complement. IgG1, G2, G3 actually binds complement, okay, and M also bind complement. G4 doesn't bind. And G4 generally is the least abundant among G1, G2, G3. G4 is least, but here, because of this antigenic stimulus, G4 is a little more. G4 actually is a bispecific antibody. Bispecific antibody in the sense that it has two antigen binding sites. So it binds and sequesters the antigen. Okay, so it's a bispecific antibody. It actually speaking binds and sequesters the antigen. So in contrast to what you think, it is not actually a core inflammatory issue. So that is the reason why in IgG4 related disease, what happens to ANA, or is there arthritis and all? If you ask me, the answer is nil. It's not present. There are no antibodies. There's no arthritis. There's no fever. Such things are not there. That's because actually speaking, it is binding and sequestering the antigen. This IgG4 as a molecule prevents the interaction of IgG1 to C1q that is required for further activation of the complement cascade. So is it a proper inflammatory molecule? It's not a proper inflammatory molecule. Then what is the problem? The problem is that it can activate myofibroblasts. Yes, it can activate myofibroblasts, and these myofibroblasts will lay down collagen, and this collagen is basically called as fibrosis. So essentially, the problem is it can produce fibrosis, and that is mediated by TGF-beta. So TGF-beta mediated fibrosis is a problem. So on one side, it is not so much of an inflammatory thing, but on the other side, it is a little bit of fibrotic thing. So this is what we understand about this IgG4 molecule right now. So let us try to get our understanding a little bit more shape. What is IgG4 related disease? You must be now telling that IgG4 related diseases are a set of conditions which are mostly tumefactive lesions, or they are tumor-like lesions. Very, very important. They have this capacity to undergo fibrosis, or there's a tendency to undergo fibrosis. This fibrosis is called a storiform fibrosis. So tumefactive lesions with the storiform fibrosis, and the fibrotic pattern is called the swirling or cartwheel appearance. So swirling or cartwheel appearance, tumefactive lesions with fibrotic. They can be even lymphadenopathy also. It need not be just the tumefactive lesion. It can be lymphadenopathy also. Alongside with that, you have obliterative phlebitis. Very, very important. There is obliterative phlebitis. In Behcet and IgG4, that is where you get obliterative phlebitis, and you have mild eosinophilia. So obliterative phlebitis, mild eosinophilia. So the background of atopy is also very important. Many times we'll be having this background of atopy, allergic rhinitis, asthma, and all in the question paper to look out for. So if you're asking me what is IgG4, it means this is what is IgG4. Tumefactive lesions or lymphadenopathy with storiform fibrosis, obliterative phlebitis, and mild eosinophilia in the background of atopy is called IgG4. Very, very, very important. Okay, if you understand this itself, then it is actually problem solved. So many diseases in the past, which we were calling with some other names, have been now reclassified as IgG4, because in the biopsy of those lesions, we have lymphoplasmacytic cells, and those lymphoplasmacytic cells have plasma cells. Plasma cells are positive for IgG4. That is the reason they have been renamed. So that's very, very clear. We will come to those major and minor manifestations. Let us get the other points very straight. Autoimmune inflammatory CTDs are generally seen in young patients, and they are mostly females. Here we are going to study about autoimmune inflammatory CTD, which can be seen in young females also, but most commonly it is seen in elderly males. So that's a very, very, very important point of difference. Second point of difference is that they don't have an acute or chronic presentation, but it is a more subacute presentation, and subacute presentation has something called constitutional symptoms. So you expect to see constitutional symptoms, not so much in the other conditions that we are going to discuss, and that is characterized by fatigue, weight loss, malaise, etc. But always remember, there is no fever. Okay, there is no fever. There is no fibrinoid necrosis. That means neutrophil infiltration, all those things are absolutely not there. There is no arthritis. So no fibrinoid necrosis, no arthritis, no fever, no granuloma. All these things you have to be careful because they are all the negative questions. So more than 60 years, males more than females, the subacute presentation, constitutional symptoms are present. So these many things have to be right there in our system. If we know this much, then deciphering the rest is going to be very easy. Let us try looking into the major manifestations first. So what are the major manifestations of the disease? If you look at the major manifestations of the disease, there are 4 major manifestations and then a big list of minors, which we will actually see. The 4 majors you have to remember. The disease was described itself with this type 1 autoimmune pancreatitis. So type 1 autoimmune pancreatitis is the single most important manifestation. Second manifestation is with respect to the submandibular gland, we will see. Third manifestation is with respect to the lacrimal gland, we will see. And the fourth manifestation is retroperitoneal fibrosis. So these are the 4 conditions that form the major manifestations. Then there are a list of minor manifestations that we will see one by one, but majors you have to remember which are the 4 majors. So first one is type 1 autoimmune pancreatitis. So type 1 autoimmune pancreatitis generally presents in more younger population. Okay, it is characterized by presentation with obstructive jaundice. Okay, presentation with obstructive jaundice, and you have exocrine as well as endocrine pancreatic insufficiency. So exocrine plus endocrine insufficiency. This endocrine insufficiency I have actually discussed under diabetes. This is a type of pancreatic diabetes, what we call type 3C diabetes. Okay, whenever you think of type 3C diabetes, your tropical calcific pancreatitis comes to mind. But alongside with that, I have told you to think about cystic fibrosis, hemochromatosis, IgG4, all that. So obstructive jaundice, exocrine plus endocrine, and you have a enlarged pancreas, which is called as your sausage-shaped pancreas. Okay, sausage-shaped pancreas. Think of sausage digit in reactive arthritis, sausage-shaped pancreas in IgG4-related disease with irregular borders. So sausage-shaped pancreas with irregular borders. Acute pancreatitis episodes can be seen, but more common presentation is obstructive jaundice presentation. Okay, that's about type 1 autoimmune pancreatitis. Then submandibular gland involvement. So there is a painless asymptomatic salivary gland swelling. So painless asymptomatic bilaterally symmetrical salivary gland swelling. So that is the best answer. So painless asymptomatic bilaterally symmetrical salivary gland swelling. And in this painless asymptomatic bilateral symmetrical salivary gland swelling, which is the gland getting involved, it is the submandibular gland getting involved, and you have only very minor Zika symptoms, very minor Zika symptoms. So Zika symptoms are not very prominent. It is the swelling that is actually very prominent, and it is a bilaterally symmetrical painless salivary gland swelling, and here it is submandibular gland. We'll try to compare and contrast it at a later point, so that time you have to be very clear. Lacrimal gland is also painless asymptomatic bilaterally symmetrical swelling. So painless asymptomatic bilaterally symmetrical swelling. The submandibular gland and lacrimal gland swelling was together called as Mikulicz syndrome in the past. Now Mikulicz syndrome is being reclassified. Retroperitoneal fibrosis was previously called as idiopathic retroperitoneal fibrosis. Now we have an answer to that. It is not just a simple idiopathic retroperitoneal fibrosis, it is IgG4 related. So that's why it can present as bilateral obstructive nephropathy. Okay, bilateral obstructive lesions, you will not know what is the cause. Patient will have lower tracking test, and when you take a CT, you will find this fibrosis. So these are the 4 major manifestations as far as the disease is concerned. So there should be absolutely no doubt with these manifestations. Let me just try to go to the head-to-foot features, and with that we will get all the minor manifestations, and then we'll draw the comparison, because comparison is very important. Let me come to the head-to-foot manifestations. When I come to the head-to-foot manifestations, naturally I start off with the CNS. In CNS, there are 2 very important points that you have to remember. One is a pituitary issue called lymphocytic hypophysitis, which is now reclassified as IgG4-related disease. I think we have discussed this in endocrine also. Postpartum females were having headache and increased ICD symptoms. So in the 90s, they were thinking that okay, there's some issue with this. They took an MRI, and MRI was showing a mass in the pituitary going and hitting on the stop. So naturally, they resected the mass, and they found out that this mass was having just inflammation. So then they decided that we shouldn't be resecting this mass anymore. Should just give steroids and see. They gave steroids. It responded wonderfully. So it was called as lymphocytic hypophysitis. But later we understood that these lymphocytes and plasma cells are made up of IgG4. So lymphocytic hypophysitis is an example for IgG4-related disease. This has been discussed in endocrine. A very important exam question itself is to compare and contrast between Sheehan syndrome and lymphocytic hypophysitis. Second is pachymeningitis. Very important. Pachymeningitis without brain parenchymal involvement. Okay, so pachymeningitis without brain parenchymal involvement. This is extremely important for the exam because you have a condition where you have pachymeningitis with the brain parenchymal involvement. That is called Behçet's disease. Pachymeningitis without brain parenchymal involvement is called IgG4-related disease. Okay, second comes orbit. Orbit, you have painful inflammatory masses. The painful inflammatory masses in the orbit is called orbital pseudotumors. So painful inflammatory mass in the orbit, which we call as orbital pseudotumor. Then of course the major salivary gland issues that we have discussed. Okay, so salivary gland and lacrimal gland is also there, but that comes in a major, so I'm not talking about it. One more point, if you want, you can remember is we'll come to Sjogren. Sjogren has lot of Zika symptoms, right, and less of swelling. Here there are a lot of swelling but less of Zika symptoms. That's the difference. In Sjogren, it is parotid gland that is getting involved. Here it is submandibular gland that is getting involved. But a very important point I want to bring on, not ask. All you can remember is we'll come to Sjogren. Sjogren has a lot of Zika symptoms, right, and less of swelling. Here there are a lot of swelling but less of Zika symptoms. That's the difference. not responsive. Is IgG4 a steroid responsive disease? Very much. Are the Zika symptoms responsive? Very, very much. So in IgG4, although Zika symptoms are minimal, they are so much responsive to steroid. Whereas in Joe, Zika symptoms are very much higher, but they don't respond to steroid. So that's the point. Everything else in Joe respond, but Zika symptoms don't respond. So that is about salivary gland and lacrimal gland. From there, we come down and we come to the lungs. Lungs is a very, very important disease consideration. When you think of lung issue in IgG4 related disease, the first major point is a very common point it shares with sarcoidosis, thickening of the bronchovascular bundle. This you should never forget. Okay, this is the key point, thickening of the bronchovascular bundle. This is seen only in two conditions. One is sarcoid and second one is IgG4 related disease. Second is the risk for ILD. And here also it is NSIP. That's a very simple question because everywhere in rheumatology it is NSIP except RA where it is UIP. And third point, which is very, very important, is paravertebral mass. The only condition where you are going to get a paravertebral mass is IgG4 related disease. So third one is paravertebral mass. Okay, when you compare it with the others, you get more understanding, but this is how it is. Then comes the vascular part. Okay, vascular part is such an important question. Vascular part alongside with the cardiac part, such an important question because in vascular part you are having vasculitis here, correct? You are having vasculitis. What is so special about the vasculitis that we are talking about here? Yes, vasculitis is 100 times special because this is the only CTD where you can get aortitis. This is very, very important to know. All the CTDs produce vasculitis. SLE produces, RA produces, everybody produces. That is how immune complex mediated small vessel vasculitis. So only vasculitis, only CTD where you are getting aortitis is a prominent manifestation. Very, very important. Okay, and that is proximal aorta getting involved more. Proximal aortitis with the paravertebral mass, etc. When you get a question for the exam, there is only one thing in the world to think, and that is equal to IgG4 related disease. Right. So these many things are very clear. Then we have the biliary tract. Now, biliary tract is an important consideration because in the biliary tract we were thinking about one disease previously, that is called primary sclerosing cholangitis. Primary sclerosing cholangitis is a fibrosing destruction of the intra and extrahepatic bile, which is studied in biliary tract. And now we understand that PSC also comes under which spectrum? PSC also comes under the spectrum of IgG4 related disease. So you're having CNS, orbit, salivary gland, lungs, vascular, biliary tract, everywhere you have IgG4, and biliary tract is primary sclerosing cholangitis. Correct. The last of the manifestations is kidney. So retroperitoneal fibrosis I told you. One thing I forgot to tell you was when I came here, thyroid. Okay, in thyroid we have something called Riedl's thyroiditis. I think all of you would have studied this during MBBS, right? Riedl's thyroiditis. That also is now reclassified as IgG4 related disease. So Riedl's thyroiditis is also now being reclassified as IgG4 related disease. Okay, kidney means it produces tubular interstitial nephritis. All these three conditions that we are going to study, most common manifestation is tubular interstitial nephritis. Second is in glomerulus membranous nephropathy. So in glomerulus, if they ask you, is membranous nephropathy, and membranous nephropathy has low complements. So generally, membranous nephropathy has normal complements. IgG4 related membranous nephropathy has low complements. That is also very important. So these many things are there to study in IgG4. So I think the head-to-head manifestations, the comparison, everything is actually in perfect shape now. Okay, and IgG4 related disease, what you do, you give steroid. It responds brilliantly to steroids. There's nothing to worry there. But now we're seeing cases with relapse. So when relapse happens, what are our options is extensively under research. But again, studies have shown that rituximab seems to work well in relapse. So that is the whole story about IgG4. So when you want to think of IgG4, individual manifestations you should be knowing head to foot, but knowing that four things are really major. Which are the four things that are major? Type 1 autoimmune pancreatitis. So look out for a question of obstructive jaundice, salivary gland swelling, lacrimal gland swelling, and of course the last one, that is retroperitoneal fibrosis. So those are the majors, and then you have this head to foot manifestation. These many things you have to must do. Okay, and of course I told you that lymphadenopathy may be there. Never forget the words tumefactive lesions, obliterative phlebitis, storiform fibrosis, mild eosinophilia, background ectopy, more than 60 years, subacute presentation, males actually. Okay, so that is about IgG4. I'm just trying to show you a few. This is submandibular gland salivary swelling. So this can be a this is a photo which is kept in many of the exams, and you may get it. And this is extensive infiltration by IgG4 containing plasma cells. This is the so-called swirling pattern and storiform fibrosis. That's going to be difficult for you to figure out. Now, second question is looking at blood levels of IgG4. Does it have a value? Yeah, it has value. IgG4 is going to be elevated, but the point is 40% of people going to have a normal IgG4 level. So only in 60% people it is going to be elevated. So that is why a bit of a problem. And from the biopsy sample, you look for IgG4 by IgG ratio. That is best. So IgG4 by IgG ratio elevated in the biopsy sample is more diagnostic. Because as more and more fibrosis sets in, what happens is that the IgG4 number cells will come down, correct? So the ratio is always going to be better. Subacute onset weight loss and fatigue, correct? Most common orbital manifestations, inflammatory pseudotumor. What gland enlargement is classical? Submandibular gland enlargement is classical. That is more than orbital pseudotumor, naturally, because that's a major manifestation. Pituitary postpartum, lymphocytic hypophysitis. Lacrimal gland plus parotid plus submandibular swelling is previously called eclipse. Now we are not calling it a name, like we're calling it as IgG4. Lacrimal is there, salivary gland is also there. In salivary gland, which is most common, it is submandibular gland that is most common. Correct. So that's it. Retroperitoneal fibrosis, yes, thickening of the bronchovascular bundle, correct. Non-specific interstitial pneumonia, correct. Paravertebral mass, tubular interstitial nephritis more than membranous. Yes, and most common manifestation is IgG4 related diseases, type 1 autoimmune pancreatitis. Can it produce exocrine and endocrine? Yes, exocrine and endocrine. Irregular shaped dilatation of the pancreas and has got some primary borders. Okay, that is due to irregular ductal dilatation. It almost looks like this. Correct. Steroids are the first line, excellent response, and steroid sparing agents that we use at the time of relapse is rituximab, but we need more data to talk on that. Correct. So discussion is pretty much in shape. Now, when I want to bring in the next discussion, that is going to be sarcoidosis. So, how do I actually compare sarcoidosis with IgG4 related disease is going to be the first crux, and then we will actually bring in one more person, that is Douglas. So, how do we compare IgG4 related disease with sarcoidosis? Okay, this is the whole point. So, when you talk about IgG4 related disease itself, I told you males more than females, 60 years is the age group they say. Subacute onset presentation is what we are talking of. This is the base that we're talking about. And you have this very, very important histological binding points, correct? Histological binding points of storiform fibrosis, obliterative blebitis, mild eosinophil, and tumor factor lesions. When you talk about sarcoidosis, histology-wise, there is nothing to study. Histology-wise, where IgG4 related disease with sarcoidosis. Okay, this is the whole point. So when you talk about IgG4 related disease itself, I told you males more than females, 60 years is the age group they say. Subacute onset presentation is what we are talking of. This is the base that we're talking about. And you have this very, very important histological binding points, correct? Histological binding points of storiform fibrosis, obliterative blebitis, mild eosinophil, and tumor factor lesions. When you talk about sarcoidosis, histology-wise, there is nothing to study. Histology-wise, there is only one thing, and that is non-caseating granulomas. These non-caseating granulomas form the crux of sarcoid as far as histology is concerned, and that is why sarcoid is a very difficult diagnosis to make also, because non-caseating granulomas can be seen in a whole lot of conditions, and that is why what is TB today may be sarcoid tomorrow, and I have done a big lecture on that. 30% of patients with sarcoid have, 30% of patients with TB have non-caseating granuloma, lymphoma have non-caseating granuloma, 20% sarcoid has caseating granuloma. It's full confusion. So we are trying to look for non-caseating granulomas, but that's why diagnosis is very difficult. So try to get as many specimens as possible and try to fix on a diagnosis. It's not easy at all. Easier said than done. And also the fact that lymphoma, TB, Katzpatch disease, borreliosis, Crohn's disease, hypersensitivity pneumonitis, all these things can have non-caseating granulomas. So it's very, very hard to establish. But histology-wise, this is the only thing that we have to study. Sarcoid can be seen in anybody above 18 years. So there's no particular age for sarcoid. Childhood sarcoid is not there. There is a disease under autoinflammatory syndromes called Bloss syndrome, BLAUS. That is very similar to sarcoid. But generally, childhood sarcoid is not there. More than 18 years, females equals males. There is no sex predilection now. It is equally seen in males and females, and it is seen more than 18 years. And it is all about this non-caseating granuloma, which has modified macrophages called epithelioid cells at the center, and it has T lymphocytes at the periphery. So modified macrophages called epithelioid cells at the center, and it is called T lymphocytes at the periphery, which are being recruited from the blood. That's why you have a very important entrance question here, what is called immune paradox. What is the meaning of immune paradox in sarcoidosis? Immune paradox in sarcoidosis means that you are having enough number of T lymphocytes in the granuloma, but in the blood are you having enough T lymphocytes? No. So what are you having in blood? Lymphopenia. So are you prone for infection? Yes, you're prone for infection. Correct. But are you having enough T lymphocytes? You're having a lot of lymphocytes, but they are all used up in forming the granuloma. So actually speaking, we are not having enough lymphocytes in the blood, but the body there are enough and more number of lymphocytes. That is the paradox. That means if you do a tuberculin skin test in this person, because he doesn't have enough lymphocytes, the response will be false negative. But it is actually speaking false negative, because it is not because he is not having enough lymphocytes, but all the lymphocytes are being used up to form the granuloma. Right? That's why we often ask, who is the person who can never develop sarcoidosis? HIV, because he doesn't have enough T lymphocytes. Not somebody with a CD4 count low, he cannot develop sarcoidosis. But the point is that you are having lymphocytes, you're developing sarcoidosis, well and good. But the fact is that in your blood you are not having enough lymphocytes. That is called the immune paradox in sarcoid. So this is the general intro part. Next point is how do you look at sarcoids? I told a list of manifestations, right? In the case of IgG4. Is it the same way that we have to look at sarcoidosis? No, that is not the way we have to look at sarcoidosis. As far as sarcoidosis is concerned, we have to look into acute and chronic sarcoidosis. That is what we have to be looking into. Because it is very important to understand that in sarcoidosis, 50% of the cases will actually resolve spontaneously. That's very important to understand. 25% will go to chronicity, and there is only 5% mortality. So it's a very different ballgame. So 50% resolve spontaneously without any treatment, 25% go to chronicity, and 5% mortality. And this chronicity is mostly with respect to interstitial lung disease. ILD. So ILD is the most common cause of death, and that is where chronicity is. And chronicity we talk more in terms of lungs, skin and eyes. These are the three things that are getting involved. If you ask me, the three major things that are getting involved in sarcoid, it is going to be lung, skin and eyes. That is how you actually look at it. So acute, from where 50% resolves spontaneously and only few become chronic. So we have to be knowing acute and then we have to be knowing chronic also. Before we know acute and chronic, is there any risk factor for sarcoid? Burning firewood and getting firewood exposure, some people say, is considered to be as a risk factor for sarcoid. So the original discussion that we are trying to do here is trying to compare between IgG4 and sarcoid. I told you the risk factors also. So when you think of sarcoidosis, I told you acute and chronic is very important. And in acute, you have two very important syndromes to remember. One is called as Lofgren syndrome, and the other one is called as Heat-Fort-Waldenstrom syndrome. So generally, in the acute setting in sarcoidosis, the patient presents with Lofgren syndrome or Heat-Fort-Waldenstrom syndrome. Lofgren syndrome, HLA-DR2 has got a very, very good prognosis. Heat-Fort-Waldenstrom syndrome has got a reasonable prognosis. You can say very good prognosis. What is Lofgren syndrome? Lofgren syndrome is actually equal to Mbbs level arthritis plus hilar adenopathy, okay, plus fever plus uveitis plus erythema nodosum. So this is how during MBBS we study. Let us try to modify it a little bit more. Uveitis is not important. Uveitis may be seen, may not be seen. Fever is also like not that important, but fever may be seen. Don't think that fever is not seen. Fever may be seen. These three most important components are arthritis, hilar adenopathy, erythema nodosum. This is the triad of Lofgren syndrome. Arthritis, hilar adenopathy, erythema nodosum. Now, when you look at it that way, I have Febrile episode of arthritis, hilar adenopathy, erythema nodosum. That also you can take it. But let us try to go into this arthritis now. This is not an arthritis, for your kind information. Please don't get it wrong. This is an acute onset bilateral angle joint. Okay, bilateral angle joint tenosynovitis. It is not arthritis. There are two conditions in rheumatology where we use the word arthritis, body myositis. It's not an arthritis. It is outside the joint. It is mostly myositis and tenosynovitis kind of thing. Similarly, Lofgren is also not an arthritis. It is a bilateral angle joint tenosynovitis and it's extremely painful. Okay, very important. So that is about arthritis. Then hilar adenopathy goes part and parcel. And in hilar adenopathy, sometimes you will be having right hilum, left hilum, and right paratracheal also. This can form a triangle. This is called the Garland sign. Okay, so please try to keep it in mind. Right hilum, left hilum, right paratracheal. That is called Garland sign. Then comes erythema nodosum. Erythema nodosum, as far as erythema nodosum is concerned, remember the 4 P's. Okay, 4 P's. What are the 4 P's of erythema nodosum? Painful P, pretibial P, papule P. Painful, pretibial, papule. Fourth P is pigmentation. Okay, so painful pretibial papule without pigmentation is the erythema nodosum that you see in sarcoidosis. Painful pretibial papule with the pigmentation is the erythema nodosum you see in Behcet. So sarcoid means only 3 P's. Last P pigmentation is. Behcet makes 4 P's. The fourth P, pigmentation, is also there. So painful pretibial papule without pigmentation in sarcoid, painful pretibial papule with pigmentation in Behcet. Okay, second of the acute syndromes is called Heat-Fort-Waldenstrom syndrome. Heat-Fort-Waldenstrom syndrome is actually characterized by, again, fever may be plus or minus. Okay, this also fever may be plus or minus, like Lofgren, uveitis, parotitis, and facial palsy. So uveitis, parotitis, and seventh nerve palsy. What are the points that you should be knowing for this? Point number 1 you should be knowing is most common neurological manifestation in sarcoid is bilateral LM and seventh nerve palsy. Very, very uncommon to get bilateral LM and seventh nerve palsy. As far as practically, I know sarcoid and GBS are the only two conditions where you can get bilateral LM and seventh nerve palsy. Textbook will tell you so many conditions, diphtheria, Lyme's disease and all that, but what you see is only these two. Parotitis is very, very important to know because it is called uveitis. And generally, you don't get parotitis anywhere. Parotid gland swelling is what you get in Sjogren. Bilateral, asymmetric, painless, parotid gland swelling. Parotitis in the acute setting, always think of Heat-Fort syndrome. Uveitis is very, very important. With uveitis in rheumatology, I have told you this. Parotitis. And generally, you don't get parotitis anywhere. Parotid gland swelling is what you get in Sjogren. Bilateral, asymmetric, painless, parotid gland swelling. Parotitis in the acute setting, always think of Heat-Fort syndrome. Uveitis is very, very important. With uveitis in rheumatology, I have told you this. Now, sarcoid and Behcet are actually speaking two conditions which can involve any compartment of the eye. Any compartment of the eye, sarcoid and Behcet can involve. That is articuloconjunctival, cornea, uvea, retina. Everywhere you can get an involvement. And in spondyloarthritis also, we can get uveitis. Correct? We can get uveitis. Spondyloarthritis, the uveitis we get is called foray uveitis. What is it? Foray? Acute anterior alternating asymmetrical uveitis. Okay. In sarcoid, you get bilaterally symmetrical anterior uveitis. So acute asymmetrical is wrong. It is acute, but it is bilaterally symmetrical anterior uveitis. So acute bilaterally symmetrical anterior uveitis. Same way you can get posterior uveitis, retinal vasculitis, anything is possible. Behcet, the most common manifestation is posterior uveitis. So in Behcet, the most common manifestation is posterior uveitis. Sarcoid, the most common manifestation is bilaterally symmetrical anterior uveitis. Ankylosing spondylitis and SPA, the most common manifestation is foray uveitis, acute anterior alternating asymmetrical uveitis. Okay, so don't get wrong. These are the two major manifestations. Arthritis, the uveitis we get is called foray uveitis. What is it foray? Acute anterior alternating asymmetrical uveitis. Okay. In sarcoid, you get bilaterally symmetrical anterior uveitis. So acute asymmetrical is wrong. It is acute, but it is bilaterally symmetrical anterior uveitis. So acute bilaterally symmetrical anterior uveitis. Same way you can get posterior uveitis, retinal vasculitis, anything is possible. Behcet, the most common manifestation is posterior uveitis. So in Behcet, the most common manifestation is posterior uveitis. Sarcoid, the most common manifestation is bilaterally symmetrical anterior uveitis. Ankylosing spondylitis and SPA, the most common manifestation is foray uveitis, acute anterior alternating asymmetrical uveitis. Okay, so don't get wrong. These are the two major manifestations with respect to acute sarcoidosis. And I told you, in few patients, 25% or so, they can go to the chronicity phase. And when you go to the chronicity phase, it is mostly with respect to the lung, the skin, and the eyes we have already seen. Because as you go to the chronic phase, you will start getting chronic uveitis, you will start getting pan uveitis, retinal vasculitis, etc., etc. So lung and skin can get involved. As for